In this lecture, we'll be discussing in detail on important short notes of the upper limb. Let us start on with the clavipectoral fascia. Under clavipectoral fascia, we'll be starting with its brief introduction, its attachments, modification, structures piercing clavipectoral fascia, its action, and its applied anatomy. In order to make you easily understand, we'll be discussing in detail about the clavipectoral fascia in a form of a diagram. To give a very brief introduction, it is a strong sheet of fascia extending from the pectoralis minor to the inner surface of the clavicle. It has four attachments: medially, laterally, above, and below. Medially, it fuses with the anterior intercostal membrane of the upper two intercostal spaces and attaches to the first rib. Laterally, it is thick and dense and attaches to the coracoid process. Above, it splits to enclose the subclavius and attaches to the lip of the subclavian groove of the clavicle. Its posterior layers has medial and the lateral part. The medial part fuses with the deep cervical fascia and the lateral part fuses with the axillary sheath. Below, it splits to enclose the pectoralis minor and ends laterally into the short head of the biceps. Let us move on to modifications. In modification, there are two important points to remember. One is the costocoracoid ligament and the other is the suspensory ligament of the axilla. The fascia thickens along the lower border of the subclavius between the coracoid process and the first costochondral junction and is called as the costocoracoid ligament. The part of the fascia below the pectoralis minor is called the suspensory ligament of the axilla. Now, let us move on to the structures piercing clavipectoral fascia. Passing outwards is the thoracoacromial artery and its branches and the lateral pectoral nerve. Passing inwards is the cephalic vein and the lymphatics from the infraclavicular nodes and the mammary gland. To talk about the action of the clavipectoral fascia, it acts as a suspensory ligament of the axilla and maintains the dome of the axilla. Now, let us summarize the most important points to be remembered under clavipectoral fascia, which we have just discussed in the form of a diagram. Let us start on with the introduction. Clavipectoral fascia is a strong sheet of fascia which extends from the pectoralis minor to the inferior surface of the clavicle. It has four attachments: medially, laterally, above, and below. Medially, it fuses with anterior intercostal membrane of upper two intercostal spaces and attaches to the first rib. Laterally, it is thick and dense and attaches to the coracoid process. Above, it splits to enclose subclavius and its posterior layer has medial and the lateral part. The medial part fuses with the deep cervical fascia and the lateral part fuses with the axillary sheath. Below, it splits to enclose pectoralis minor and ends laterally into short head of the biceps. Now, let us move on to modification. Under modification, there are two important points you need to remember. One is the costocoracoid ligament and the other one is the suspensory ligament of the axilla. The fascia thickens along lower border of subclavius between coracoid process and first costochondral junction and is called as the costocoracoid ligament. The part of the fascia below its pectoralis minor is the suspensory ligament of the axilla. Now let us move on to the structures piercing clavipectoral fascia. So those passing outwards are thoracoacromial artery and its branches and the lateral pectoral nerve. Passing towards is the cephalic vein, lymphatics, and under lymphatics is the infraclavicular nodes and the mammary gland. In order to remember thoracoacromial artery and its branches and lateral pectoral nerve, cephalic vein and the lymphatics, remember the mnemonic Tintin-like Caesar's looks, where T stands for thoracoacromial artery and its branches, L for lateral pectoral nerve, C for cephalic vein, and looks L for lymphatics. Let us move on to action. Under action, remember just these two important words, which is suspensory ligament and axilla. Now make the sentences. Clavipectoral fascia acts as a suspensory ligament of the axilla and maintains the dome of the axilla. The last one is the applied anatomy. Under applied anatomy, remember back door exit. So what is back door exit? When the malignant cells of the breast pierce clavipectoral fascia and go to the raters and to the apical group of the lymph node, it's called as the back door exit. Now, let us discuss about deltoid muscle. The topics covered under deltoid muscle will be its brief introduction, detail about its origin, insertion and action, nerve supply, structures under cover of deltoid and applied anatomy. Now, let us start with the introduction of deltoid. Deltoid is a triangular multipinnate muscle present in the shoulder region. And let us discuss about the synonyms of different fibers of the deltoid. The anterior fibers of the deltoid is also known as the clavicular fibers. Middle fibers is also known as the acromial fibers, and the posterior fibers is also known as the scapular fibers. Anterior fibers and the posterior fibers are long and parallel. Middle fibers are multipinnate. The range of movement in anterior as well as posterior fibers is more, whereas in case of the middle fibers, the range of movement is less. The force of pull in respect to anterior and the posterior fibers is less, whereas the force of pull in case of middle fibers is more. Now, let us discuss in detail about the deltoid muscle. The deltoid is a 3-in-1 muscle, and the deltoid is shaped like the inverted Greek letter delta, hence it's called as the deltoid. The deltoid has a V-shaped origin from the subcutaneous bony arch formed by the lateral one-third of the clavicle, the acromion process and the crest of the spine of the scapula. The anterior unipinnate part arises from the upper surface and the anterior border of the lateral one-third of the clavicle. The middle multipinnate part arises from the lateral margin and the upper surface of the acromion. The posterior unipinnate part arises from the lower lip of the crest of the spine of the scapula. Now let us move on to its insertion. The fibers converge inferiorly to form a short thick tendon which is inserted into a V-shaped deltoid tuberosity on the lateral aspect of the midshaft of the humerus. Now let us discuss about its nerve supply. The deltoid is supplied by the axillary nerve, which is C5 and C6, from the posterior cord of the brachial plexus. The anterior clavicular fibers are the flexors and the medial rotators of the arm. The posterior, the spinous fibers, are the extensors and the lateral rotators of the arm. The middle, which is the acromion fibers, are the strong abductor of the arm from 15 to 90 degree. Now let us discuss about its clinical correlation. The common site of intramuscular injection is deltoid. The intramuscular injection are commonly given in the lower half of the deltoid to avoid injury to the axillary nerve, which winds around the surgical neck of the humerus. Now let us move on to the nerve supply. The nerve that supplies to deltoid is the axillary nerve from the C5 and C6 of the posterior cord of the brachial plexus. Let us move on to the structures under cover of the deltoid. Let us start with the bones. Upper end of the humerus with greater and lesser tuberosities, intertubular sulcus, upper part of the shaft and the surgical neck of the humerus. The second one is the coracoid process of the scapula. The muscles attached to greater tubercle is the supraspinatus, infraspinatus, teres minor, and to the lesser tubercle is subscapularis. To the glenoid cavity is the long head of the biceps and the triceps, and to the coracoid process is the origins of the coracobrachialis and the short head of the biceps, which is the infraglenoid tubercle. In order to remember the muscles that come under greater tubercle, remember the mnemonics SIT, where S stands for supraspinatus, I for infraspinatus, and T for teres minor. In order to remember the muscles that come under coracoid process, remember the mnemonic cricket bat, where first C stands for coracoid process, The other C stands for coracobrachialis and the B stands for biceps. And to remember the muscles that come under glenoid cavity, remember the mnemonic LGBT, where G stands for glenoid cavity, B for biceps and T for triceps. Now let us move on to the vessels. It is the anterior and the posterior circumflex humeral vessels that present in the region of deltoid, and it is the axillary nerve which we have already discussed under the nerve supply. The joints and the ligaments present in the region of deltoid is the shoulder joint and the coracoacromial ligament. Subacromial and subdeltoid bursae and the bursae of shoulder joint is basically present in the region of deltoid. Now let us move on to applied anatomy. Fracture of the surgical neck of humerus causes lesion of the axillary nerve and it results in the paralysis of the deltoid. Next one is the intramuscular junction, which is done in the lower half of the deltoid. You might think, why does it happen in the lower half of the deltoid? It happens because to avoid the injury to the axillary nerve which winds around the surgical neck of the humerus. Now let us move on to the axillary lymph nodes. Now let us discuss about the axillary lymph node. There are only 5 axillary lymph nodes, which are anterior, central, posterior, lateral and apical. The anterior lymph node is situated along the inferior border of the pectoralis minor. It receives from the lateral half of the breast and drains into the central. The posterior is situated along the subscapular vessel and it receives from the axillary tail and drains into the central. The lateral is situated along the posterior medial of the axillary vein. It receives from the upper limb and drains into the central. The central is present along the base of the axilla and it receives from the anterior, posterior and lateral and drains into the apical. The apical is present in the apex of the axilla, medial to the axillary vein, and it receives from the central and drains into the subclavian trunk and the thoracic. Let us discuss about its applied anatomy. There is an enlargement of the anterior axillary group of lymph nodes in the malignancy of the lateral half of the superficial and the deep structures of the mammary gland. This table summarizes the most important points to be remembered under the axillary lymph node, which we have already discussed in the form of a diagram. Please do go through this table. Now let us move on to brachial artery. The topics that will be covered under brachial artery is its origin, branches, course and relation, and its applied anatomy. Now let us discuss in detail about brachial artery. To give a very brief introduction, brachial artery is a continuation of axillary artery below the lower border of the teres major. Now let us discuss about its branches. Muscular branch. The muscular branch branches to the muscle of the anterior compartment of the arm. The profunda brachial artery is the largest and the first branch. It arises from the posterior medial aspect of the brachial artery, and along with the radial nerve, it leaves the lower triangular intramuscular space to enter the spiral groove. The nutrient artery of the humerus enters the nutrient foramen of the humerus located near the insertion of the coracobrachialis. The superior ulnar collateral artery arises near the middle of the arm and accompanies the ulnar nerve. The inferior ulnar collateral artery, also called as the supratrochlear, arises near the lower end of the humerus and divides into anterior and the posterior branches. The radial and the ulnar artery are the terminal branches. Now let us discuss about the applied anatomy of brachial plexus. Rupture in the brachial artery in the supracondylar fracture of the humerus may lead to Oxman contracture. So this is the supracondylar region. Now I'll be summarizing the most important points to be remembered under brachial artery that come under its origin and branches. Brachial artery is a continuation of axillary artery below the lower border of teres major. Now let us move on to the branches. In order to remember all the branches, remember the mnemonic muscle pro is a multi-nutrient supply for infants who are underweight, where muscle stands for muscular branches, pro for profunda brachii artery, nutrient for nutrient artery to humerus, supply for superior ulnar collateral artery, and infants for inferior ulnar collateral artery, R for radial, and underweight U for ulnar artery. Under muscular branches, remember that muscular branches are to the muscles of the anterior compartment of the arm. Under profunda brachii artery, remember that it is the largest and the first branch which arises from the posterior-medial aspect of the brachii artery, and it leaves the lower triangular intramuscular space. Under nutrient artery to the humerus, remember that it enters the nutrient foramen of the humerus, which is located near the insertion of the coracobrachialis. Under superior ulnar collateral artery, remember that it arises near the middle of the arm and accompanies the ulnar nerve. Under inferior ulnar collateral artery, remember that it is also called the supratrochlear, which arises near the lower end of the humerus, and it divides into anterior and posterior branches. Finally is the radial and the ulnar artery, which are the terminal branches. Let us move on to course and relation. Brachial artery is superficial throughout its course and is accompanied by venae committens, which is the brachial veins. The brachial artery accompanies medial nerve, the profunda brachii, which is a branch of a brachial artery, and the anterior descending artery, which is a branch of the profunda brachial artery. Both of them accompanies radial nerve. The superior ulnar collateral artery, which is a branch of the brachial artery, accompanies ulnar nerve. Remember the mnemonic bypass, where B stands for brachial artery, P for profunda brachii, A for anterior descending artery, and S for superior ulnar collateral artery. Now let us move on to its relation. Skin, superficial fascia, deep fascia, biceps brachii, bicipital aponeurosis at the bifurcation, all these are its anterior relation. Long head of the triceps, medial head of the triceps, coracobrachialis and brachialis is its posterior relation. Upper part of the median nerve is its lateral relation, and medial cutaneous nerve of the arm and lower part of the median nerve is its medial relation. The artery divides at the neck of the radius into radial and the ulnar artery, which is known as its termination. Now let us move on to the last section of the topic, which is the applied anatomy. Rupture of the brachial artery in the supracondylar region of the humerus may lead to Oltzmann contracture. The picture depicts Oltzmann contracture. We have discussed about clavipectoral fascia, axillary lymph nodes, deltoid muscle and brachial artery, and also summarized the important needed points to be written when asked as a short note. To upgrade and enrich your medicine in the fingertips and to also get updated with the shortcuts and techniques, do subscribe our channel.